Good afternoon to all of you. I have the pleasure to welcome Dr. Bhawna Sirohi for this talk, Evolving Role of Immunotherapy in Esophageal Cancer. Now, Dr. Bhawna Sirohi certainly needs no introduction. Just for the sake of formality, she is the medical director at Balco Medical Center, Raipur. She has many decades of experience in the NHS as well as in India. And she has published more than 150 papers in various journals. Her research and clinical interests lie in mostly breast and GI cancers. And she is also sits on the ASCO Committee for Health Equity and Outcomes. So without wasting any more time, I request Dr. Bhawna to proceed with her talk.
Thank you so much, Doctor, and thank you, Dr. Animesh, for inviting me to this. I wish I could be there in person. If you could stop, if Kavina could stop sharing the screen, I will just share my screen. Great, thank you. So it's indeed a pleasure to talk on evolving role of immunotherapy, because that is the one development that has happened, which has actually made a difference to our patients in improving not only their quality of life, but also living longer. The center I'm at, less than 1% of my patients can afford immunotherapy, but I'm sure this is the story in over all of India. But I'm hoping that the prices will come down, and hopefully we'll have a biosimilar very soon, so that we are able to treat more patients with this. The Indian data is that the stomach cancers are going down, and I think that's reflective of all infection-related cancers and lifestyle-related cancers like esophageal cancer, mainly related to tobacco, are going up. The treatment strategy for upper GI cancers...
Ma'am, sorry to disturb you. Ma'am, request you to please make your screen full screen.
It is full screen. It's hide presenter view, should I put?
Just a second.
Ma'am, currently you're sharing the tab, ma'am. If you can give me the permission, I'll just... Perfect, ma'am. Now
is it okay now?
Yes, ma'am.
Okay, thank you. So the treatment strategy is, yes, of course, we should, most cancers, we were very lucky in the NHS that we had site-specific oncologists, but we know that in India, we are heavily short of medical oncologists in the country. So we cannot go for site-specific oncology. I would prefer that the treatment has become so complex that we need to have treatment for at least patients with the curative intent in high volume centers, and follow some guidelines as well. The ICMR has guidelines, as the Indian Council of Medical Research, and the National Cancer Grid also has guidelines. And so that most of our patients, or all of our patients, get uniform treatment as they do in the NHS as well. The established routinely that we do for patients is HER2, MSI, and PD-L1. And what is emerging is FGFR2b, Claudin 18.2, and minimal residual disease, which I will not touch actually. I will not discuss HER2 as well. I will just focus on immunotherapy. And because we have a lot of students, one second, I will just stop the video. So because we have a lot of students, I will also talk about mismatch repair deficiency, which is 8 to 10% of our patients with operable cancers are deficient in mismatch repair, or MSI instable, and about almost 5% of stage 4 cancers, more likely to be proximal, more likely to be ladies, and higher median age. So recently, the ASCO, the CAP and the AMP guidelines have come in. I think we have to be aware of these, because MSI has to be done by immunohistochemistry or by PCR, and not by NGS, because this is what we are seeing in the clinic quite a lot nowadays. And TMB should not be used as a surrogate to start immunotherapy. I think if a patient has a high TMB, then one must perform IHC or PCR and confirm that the patient is MSI unstable or has an MMR deficient sample. Like in this sample, there is absence of MLH1 and PMS2. And again, I think these guidelines came in now in October last year, published now, but the approvals happened before. But I'm glad that these guidelines have come out so that, you know, we can follow them for our patients and do MSI in the right way. Again, there is a lot of confusion in clinic, which I face as well. So it's very important to know what the obligate partners are, whether your IHC is truly correct, because based on this, you are going to start patient on a treatment which is very, very expensive. And all of these need to be taken into consideration. And also the patient should be referred for genetic counseling to detect the 10% familial cancers which may come up. And we're again very short of geneticists in India. So telegenetics is the way forward, and this is what I use at my center currently. Why is MSI testing so important? For early or locally advanced or operable gastroesophageal cancers, it is a prognostic and operable. And I think nowadays we are questioning whether some of these patients truly need to have chemotherapy at all, because they are actually chemo-resistant. And this has been shown in MAGIC and the classic study, and also in the meta-analysis, that there is no benefit of chemotherapy in patients who are deficient in MMR. MMR is also predictive in advanced patients with advanced cancers. So the future is MSI-driven therapy, and I think in operable cancers, there are trials going on with immunotherapy with the neoadjuvant. The study with the NeoNIPIGA trial showed a complete pathological response of almost 60% in patients who had neoadjuvant nivolumab, ipilimumab. And again, the first-line studies have shown greater response rate in patients who have MSI high tumors. Whether we can avoid giving them chemotherapy and just recommend surgery, I don't think we are there yet. But if I have a patient who's had surgery and has had an MSI high tumor, the performance status is borderline, or an elderly patient, then I have less hesitation in recommending that patient for upfront surgery, or maybe avoiding chemotherapy post-operatively. But again, that is in those patients where the decision is borderline. PD-L1 testing is the other test which actually drives immunotherapy in our clinics. And again, there is a lot of there are a lot of issues relating to PD-L1 testing in all cancers, especially in upper GI cancers. The platform to be used, the antibody to be used, the subjectivity with the reporting from the pathologist, and the result interpretation, whether you use combined positive score or tumor positive scores. And again, each of these agents has a companion diagnostic. So you have to use the right companion diagnostic. I will not going to spend too much time on it, because this is a half-an-hour lecture. And I heard to a couple of my colleagues, Raghav Sundar and Elizabeth Smith, talk about it. And I think if you want to, you must listen to those lectures, because, and the other thing is that PD-L1 testing is dynamic and changes with chemo and radiotherapy. So when you're doing your adjuvant decision-making, how do you go about it, especially in patients with residual tumors? So coming on to the studies, again, I'm going to discuss the pivotal practice-changing studies, and not all the studies which have been done with immunotherapy because of paucity of time. This is a randomized clinical trial, double-blind, with patients who had residual disease after pathologic disease after neoadjuvant chemoradiotherapy. And with good PS, almost 800 patients. They were randomized to nivolumab and placebo, and given up to 1 year or until progression or toxicity, with a primary endpoint of disease-free survival. These patients were followed up for 2 years. And I think this trial is very important, because we know that in these patients, the risk of recurrence is almost 70 to 80%. So I think we need to do something different to see whether we can decrease this risk. And as you can see that the disease-free, the study met its primary endpoint and is practice changing, that patients who had nivolumab had a significantly better disease-free survival of about 22 months, almost double, 11 versus 22 months. And if you look at the histology, and we know with immunotherapy, the squamous cells, or with radiotherapy, the squamous cells tend to do slightly better. And this is reflected here as well, that the patients 19 versus 11 versus 30 months versus 11 months in squamous cells. So the benefit was definitely higher. The one thing I would like to point out in this study is that, which was quite interesting for me, was that patients who received nivolumab, the magnitude of benefit with respect to the DFS was greater in those who started it about 10 weeks after surgery than in those who had it before. I think this is reflective of the intensive treatment of chemoradiation and surgery. So I think there is a prolonged recovery needed for these patients before they can start another intensive treatment with immunotherapy. I just want to talk about this one study. Again, I know it's a negative study with adjuvant durvalumab and squamous cell esophagus, 86 patients, small number. This study did not meet its primary endpoint and showed that there is actually no benefit of adding adjuvant immunotherapy with durvalumab. But again, it's a small number of patients. The control arm, that is the placebo arm, did amazingly better. And but this study showed that that the post chemoradiation PD-L1 status can help predict the survival of patients who received adjuvant PD-1 or PD-L1 inhibitors. And this study had also included patients with pathological complete response. So I think we must keep this in mind, especially with whether the different drugs are different. That could also be, but again, it's a very small study. Coming on to the first line patients with advanced esophagogastric cancer. I will take up adenocarcinoma, the checkpoint 649 study first, which randomized patients to nivolumab plus fluoropyrimidine platinum versus standard chemo K-Pox or Folfox versus nivo-EP times 4 followed by nivolumab alone given every 2 weeks. Almost 2,000 patients recruited in this study, the co-primary endpoint of overall and progression-free survival, especially in patients with PD-L1 with a CPS of 5. And as you can see, the study showed that this was a practice-changing study and led to approval of nivolumab. This showed that patients did live significantly longer, 14 months versus 11 months. The benefit was almost 2 months for a patient who received nivolumab. The patients had a two-year follow-up with a hazard ratio of 0.70 for PD-L1 CPS more than 5, and there was no overall survival benefit for patients whose PD-L1 was less than 5, though the overall response rate was independent of the PD-L1 status. So coming on to the third arm, which was published last year, the nivo-EP arm versus chemotherapy. They looked at the secondary endpoint of overall survival, and actually this did not meet its pre-specified boundary for significance. The response rates were lower than chemotherapy, and I think this could be due to, as per the authors, early mortality with the nivo-EP. And most of us who've used ipilimumab know that how toxic the drug can be related to its side effects. Versus chemotherapy, and also there's a crossover of the Kaplan-Meier curves. If you look at the immunotherapy in first line, these are the 3 pivotal trials: Keynote 062, Checkmate 649, and Orient 16, done in China. In the last 2 studies, almost 60% patients had a CPS score of more than 5. And all of these studies are positive in favor of use of immunotherapy in first line setting, and the benefit is more. So I'd like to bring your attention to the grade 3 to 5 AEs, which are not insignificant, which are almost 60%. And these do increase. The cost of drug is high, but the cost to the patient, the financial toxicity to the patient as a result of the AEs is also quite significant, which we must not forget. Coming on to the second study, which is Checkmate. This is in squamous cell cancers. Patients were randomized to nivolumab plus chemo. So the 5-FU plus cisplatin versus nivo-EP versus chemotherapy, very similar design. Again, this did show that there was patients who had a PD-L1 expression of more than 1%. There was a significant benefit in overall survival, almost 15 months versus 9 months, and also in overall population, 10 months versus 13 months. And the progression-free survival was also significantly better in squamous cell. If you look at the Orient 15, that also showed that patients with first-line advanced metastatic squamous cell esophageal cancer did significantly better. And this study actually shows the clinical utility of a marker that doing PD-L1, whether it's CPS or TPS, both of these showed that there was a significant benefit. So this actually shows that the marker is robust, though there are challenges with it, as we know that. If we look at the regulatory approvals, which are FDA or EMEA approved, again, both for squamous cell and I will not discuss the second line data or third line because for adjuvant, I think nivolumab, again, irrespective of biomarker, is approved for those who have residual disease. Pembrolizumab for first line, again, no biomarker by FDA, but EMEA would like a PD-L1 CPS of more than 10. I think the whole point of this slide is the approval is different. So I think in each of your countries, it is one has to look at what the approval is. In India, I think we tend to follow EMEA, and which is more towards resource limited patients. And for me, I would actually do the PD-L1 CPS score based on the companion diagnostic before considering patient for immunotherapy, because we know that the magnitude of benefit will be larger in these patients. And again, TMB is there in second line gastric, as you can see, more than 10 mutations, but the current guidelines that have come up actually say that TMB high alone should not be taken as it should. The patient should have an MSI high cancer as well. So I think briefly, I would say that MDT care absolutely essential. NGS I have not discussed, but this is something again which we do, but it should not guide the treatment decision making for MSI or with just TMB alone. MSI testing, very important that it is done robustly, and we should consider genetic assessment. PD-L1, I would suggest using a validated assay and platform. Adjuvant decision making, if PD-L1 is to be used, whether it should be, the PD-L1 should be tested before at diagnosis, and sometimes we do it on the archival sample, or should it be done in the sample post chemoradiation in those patients who do have residual disease, which is, I think, what we should do, because it is dynamic and it changes. It does improve survival both for adenocarcinoma and squamous cell carcinoma, though the greater benefit is seen in biomarker enriched population. I have not spoken about EBV, but that is also coming up as a marker that these patients tend to have a better prognosis. We know that in head and neck cancers, the treatment has been de-escalated in patients who are EBV positive, HPV positive, not EBV. So, but in gastric cancer, we know that these EBV positive patients have a better prognosis and are more likely to have an MSI high or a PD-L1 positive cancer. Thank you.
Thank you, Dr. Bhawna, for another excellent lecture. If there are any questions in the chat box. No.
So Dr. Indranil,
Yeah.
I have a question. This is Ankur.
Hi, Ankur. How are you?
Yeah.
I'm good. So, madam, I have a question. So many of our patients come to us as a second line or a third line therapy. And initially they have got platinums, 5FU, taxanes, or whatever is the standard first line therapy. When the patient comes to us second line and third line, so do you use this immunotherapy with combinations with chemotherapy? Suppose PDL1 done and PDL1 comes out to be, CPS comes out to be 20%. So are you keen on adding immunotherapy with chemotherapy in second line, third line in stomach or esophagus cancer? Is there a data behind it?
So, I mean, there is some, but not very robust. So what I tend to do, let's say gastric cancer, I tend to use second line, I tend to use paclitaxel ramucirumab routinely. And then I reserve immunotherapy for third line because, the data for ramucirumab taxane is quite robust in second line in gastric cancers. But let's say if you have an esophageal cancer or a squamous cell cancer, then I have a low threshold of using immunotherapy. Then, I tend to go more in favor of immunotherapy rather than ramucirumab and taxane.
So just one last 10 seconds. If a patient comes to you post-FOLFOX as a second line therapy and CPS is 20%, you will use Rainbow Regard or you will use taxane plus immunotherapy?
So I think I would use taxane plus again, most of these patients, Ankur, they have third line, fourth line. So there is no right or wrong answer. You can go for second line immunotherapy as well, along with if they, depending on the disease-free interval, I would use FOLFOX again, or use irinotecan single agent, or along with paclitaxel or FOLFIRI. So these would be your chemo backbones. But you would not be wrong in adding immunotherapy second line if the CPS score is 20. I mean, the patient is very likely to respond to immunotherapy.
Thank you.
Thank you.
Yeah. So there is one question by Dr. Roshni. What about combining HER2 new targets with IO? I think you briefly.
So again, we have the keynote study which shows that my first line for patients with, I just have a couple of patients who are on FOLFOX, trastuzumab, and pembrolizumab. The CPS in this patient is more than 5. But it is irrespective of CPS. Also, you could combine it.
Yeah, but as you showed, it is not yet approved by the EMA, only by the US FDA.
Absolutely.
Yeah. So thank you, Dr. Bhawna, again. Hope to see you again in a short time. Till then.
Thank you so much. Thank you.
Thank you, madam. Thank you for.
Thank you, Dr. Animesh. Thank you all.